Hello, everybody. Thank you for coming, and thank you for inviting me to talk here. So my name is Dr. Annabella Pascucci. Like she said, I'm at the UCLA Health office in Redondo Beach. So we actually do have a clinic here. We have primary care doctors and multiple specialties in our clinic. It's right on Prospect Avenue where the Beach Cities Health District is. So that's where I am Monday through Friday. So if I'm not speaking loudly enough, please let me know and I'll speak up. I have a tendency to not speak as loud, so just raise your hand, tell me to speak louder. So today we're going to cover, first of all, what is skin cancer, how to prevent skin cancer, and in that we'll talk about sunscreen. I'll talk about the different types of skin cancer and their treatment, and also, of course, how to detect skin cancer. And in talking about that, I'll talk about a few common benign skin lesions that we have. So what is skin cancer? Well, skin cancer is the abnormal growth of skin cells. It most often happens on areas of the skin that are exposed to the sun more, like the face or the arms, but it can happen anywhere on the body. It's also more common in people that have lighter skin, but again, it can happen on anybody. And it is pretty common, especially in sunny Southern California here. It's thought in all of the United States, about 1 in 5 Americans will be diagnosed with skin cancer in their lifetime. So how do you prevent it? Well, if it's that common, we want to try to prevent it. So the best way to do that is to protect yourself from the sun. And the best way to do that is to avoid the sun if you can, but we all like doing things outdoors. So if you're going to be outdoors, then apply sunscreen, and I'll go over sunscreens a little bit more. Make sure you seek shade. So remember that even if you're in the shade, the sun will still bounce off sand, water, snow, so you will still be exposed to UV rays even if you are in the shade. So you always have to be careful and wear your sunscreen. Also, try to avoid being out in the sun in the peak UV hours of the day. So that means between 10 a.m. and 2 p.m. Try your best not to be outside in the sun. Also use sun protective clothing. That means hats, sunglasses, long sleeves. That works much better than sunscreen. And also try to avoid tanning beds or sun lamps. Those have a lot of the bad UV light that you get exposed to. So if you like to have a tan color, try using spray tan or self-tanning creams. Those are considered safe. And also remember to get your vitamin D safely. You can get vitamin D not only from the sun, but you can get it through your diet and with supplements. So how do you choose a sunscreen? You're at the store, there's a big aisle, there's all sorts of brands, all sorts of options. Make sure you choose one that is broad spectrum. That means it covers both UVA and UVB. The older sunscreens used to only cover UVB, so they would only prevent sunburn, but you could still get the exposure to UVA rays that cause skin cancer. The newer sunscreens in the last couple of years are much better about this, about being broad spectrum, and they cover both UVA and UVB. Also remember to get a high enough SPF. The American Academy of Dermatology recommends at least 30 or above. So for the face, 30 on the body. You can even go higher if you're going to be out in the sun for long hours. Also try to choose one that is water resistant. That means that if you are out in the water or sweating, it tends to last a little bit longer than the regular sunscreens, but it still means you have to reapply. The label should say water resistant 40 minutes or water resistant 80 minutes. So after 40 minutes or 80 minutes, you're supposed to reapply. And this is just a handout that's provided on the AAD, or American Academy of Dermatology website, where it just has a kind of explanation of what I just went through. Remember to get SPF 30 or higher, broad spectrum, water resistant, a recommendation to use enough sunscreen. So it's important to apply your sunscreen about 15 minutes before you go out. The reason being so you can absorb the sunscreen, and also so that when you're putting on your clothes or sit in a chair, it doesn't just rub off your skin. Also use enough, like I was mentioning. You should use about 1 ounce or a shot glass's worth of sunscreen on your entire body if you have, a lot of area exposed, like if you're wearing a swimsuit. So a lot of us don't use enough, so make sure you use enough of it. And then apply to all areas that are exposed to the sun. Areas that are often forgotten are the scalp, if there's thinning hair. Also the ears, the neck, and the top of the feet are areas that are often forgotten. So don't forget, every part of the body should be protected. And then reapply every 2 hours if you're continuing to be outdoors. And reapply after swimming or being in the water, or if you're excessively sweating. So why use sunscreen? Well, sunscreen is considered safe. There's been lots of studies to show that it is a safe thing to use. It prevents sunburn, it reduces the risk of skin cancer, and it also reduces premature aging. So it prevents wrinkles, sunspots, discoloration, so it makes you look prettier. So how do you detect skin cancer? Well, before I get to that, we should know what skin cancer looks like. And in doing that, I'll go over the most common skin cancers and also a precancer lesion that is very common. So I'll start with that. Actinic keratosis, or shortened AK, is very common. It's considered a precancerous lesion because a small percentage can go on to become a skin cancer called squamous cell carcinoma. They usually look like the temple of that person there. They are dry, scaly, rough, pink patches. A lot of times if you go to your dermatologist, you'll notice they start feeling your skin. They're like touching your nose, your ears, while they're trying to feel for rough areas, because a lot of times the skin starts out rough before the pink obvious lesion comes up. And common locations are areas on the body that get the most sun. So that would be the head, neck, hands, forearms, but they happen anywhere on the skin that has had a lot of sun exposure. So who is at risk of getting these? Well, people with fair skin, people with naturally blonde or red hair, people with light-colored eyes, or with skin that freckles easily or burns easily in the sun. Older age, meaning 40 years or older, which is much earlier in Southern California where we grow up in the sun, or in people that have used lots of tanning beds. Also, people that have a weak immune system, either because of a medical condition such as HIV or AIDS, or because they have to take immune suppressive medications, such as patients that have an organ transplant. Also, in patients that have worked with substances such as roofers, coal or tar have polycyclic hydrocarbons that increase the risk of having these precancerous lesions. So how do you treat them? The most common way to treat these AKs, or actinic keratosis, is by freezing them, and that's called cryotherapy. We use liquid nitrogen to freeze the abnormal cells, and you'll get a little blistery, scabby spot. Takes a few days to a few weeks to heal. Depending on the location and how hard you need to freeze, it may take a few weeks to heal, and it could leave a little white discoloration. In people that have diffuse actinic damage, so lots of sun damage, then we sometimes need to use creams to treat the whole area that has sun damage. For example, maybe the whole entire face, or both arms if there's been a lot of sun. The medicines that we tend to do that are prescription medications that you apply yourself at home. It's either daily or twice daily for many weeks, depending on the medications. And the ones that we typically use are 5-fluorouracil, or the trade name is Effidex, imiquimod cream, trade name is Aldera, Ingenol gel, trade name is Picato, or diclofenac, the trade name for that one is Solarace. Don't know if any of you have used them, but those are the most commonly used ones. So basal cell is the most common type of skin cancer, and it looks something like that in that picture. It tends to be sort of pearly to flesh-colored, a little pink, sometimes has a central dell, lots of blood vessels, and the main thing it does is it tends to bleed. It's a spot that bleeds, heals, starts to bleed again, just doesn't tend to go away and keeps growing. So who gets basal cells? Well, it's similar population that gets the precancer lesion that I just talked about, the AK. So people that get basal cells are those people that have fair skin, light hair, light eyes, Also, people that have had a lot of sun exposure, especially people that have had indoor tanning exposure. If they've had a history of a prior basal cell, then they're at higher risk than the general population of getting a second or third one. Again, people that have an immune system that's not working properly for whatever reason. And those people that have had overexposure to x-rays, that usually includes people that received x-ray treatments for acne back in the 40s. So what causes it? Well, UV damage causes basal cell. The UV radiation directly causes DNA damage in the cells on our skin. Usually our body can repair some of it, but if there's been enough damage, then that's when a basal cell develops. How do you diagnose it? Well, if you have a spot that looks concerning, you'll go to your dermatologist. They'll take a look at it. They'll say, yes, it needs a biopsy. The next step will be numbing up the skin, taking a piece or all of it, and sending it to the lab to be looked at under the microscope. At that point, if the diagnosis is confirmed, then you have to treat the lesion. So how do you treat it? Well, basal cell, although it has very low risk of metastasizing, meaning traveling to a distant organ in your body, it does continue to grow if it's not treated. And so it will grow and can grow into cartilage and bone, and so it can be quite disfiguring if it's not treated. So we do prefer to treat them, and there's many treatment options as listed there. In the basal cells that occur on the trunk and extremities, meaning on the chest, abdomen, back, arms, legs, what we tend to do is something called surgical excision. So we'll numb up the skin just like we did for the biopsy, so it's just an in-office procedure, and we get a standard 5mm margin around it, and we get underneath it. And we send that tissue off to the pathologist, and we sew you up. A week or two later, you'll get the report to find out if you removed all the skin cancer. The reason for the standard 5mm margin is because the majority of the time it's removed with that margin. If it's a very superficial basal cell, sometimes we'll do something called curettage and electrodesiccation. That involves, again, numbing up the skin and scooping out the skin cancer and burning it. Now, we don't get the confirmation that we do with the excision of cutting out the tissue, but we can tell by the way it feels if the skin cancer is still left, and it is important to keep getting the area checked to make sure it doesn't look like anything is coming back. Also, you'll have a different looking scar. With this, you'll have a circle. With the excision, you'll have a line because there's been stitches in place. In areas where it's very cosmetically sensitive or there's not that much skin available to work with, then we'll do something called Mohs, micrographic surgery. That involves, usually we use that on the face, hands, or feet. That involves, again, numbing up the skin in-office procedure and getting a very narrow margin around the skin cancer. And then while you wait in the waiting room, the Mohs surgeon will process the tissue, look at it under the microscope, see if there's any skin cancer left on the edges. And then they've drawn out a map, and if there's any skin cancer left, they'll go just to the area of skin where the skin cancer is left. So they preserve the greatest amount of normal tissue. So that's why we use that for the face, hands, feet, and if there's a large or aggressive skin cancer. The same medicated creams that can be used for the precancerous lesions can be used for superficial skin cancers as well, just the treatment is usually a little bit longer. We can also freeze them with cryosurgery using liquid nitrogen, but again, that's just for superficial, not aggressive skin cancers. In very large or inoperable lesions, for whatever reason, because of location or because of patient's health, sometimes we'll do radiation or an oral chemotherapy medicine called vismodegib. So moving on to the second most common type of skin cancer is squamous cell carcinoma. Again, it's usually a red, bleeding, crusty spot that just doesn't tend to heal. So the theme keeps being something that bleeds and doesn't heal, you should get checked out. Again, they can happen anywhere on the skin, and in the people that tend to get squamous cells is the same group that can get basal cells, people with light skin, lots of sun, light hair, light eyes. But there is a range of other things that can predispose you to get squamous cells. And that involves being exposed to cancer-causing chemicals, such as arsenic in drinking water and those that grew up with well water. Also, if anyone has a history of smoking, that increases your chance of getting squamous cell carcinoma of the lips, tongue, or inside the mouth. Also, if you spent a lot of time near heat, if you have a history of a lot of actinic keratosis, which are those precancerous spots, if you have a history of a severe skin burn that causes scarring, if you have a history of a non-healing ulcer, such in those people that have poor circulation on the legs and have an ulcer for a long time on the lower extremities, in people that have had a history of human papillomavirus, that's the virus that causes warts, certain types of this virus can be predisposing people for squamous cell carcinoma. Also, again, people that take medications that suppress their immune system, or if they have an immune system that doesn't work for another reason, or overexposure to x-rays. So what causes squamous cell? Well, again, radiation, UV damage, and then having exposure to a lot of the things I just mentioned causes chronic inflammation, and that chronic inflammation can go on to cause a squamous cell carcinoma. How do you diagnose it? Same as a basal cell. You see a suspicious spot, you numb it, take a piece or the whole thing, send it to the lab, look at it under the microscope, and then a week or two later you get your result. So early diagnosis and treatment of squamous cell is even more important than basal cell. A small percentage of these can go on to spread to lymph nodes and distant organs, especially those on the lips, on the scalp, on the ear. So it's important to get them treated early so that that doesn't happen. The treatment options are very similar to the basal cell. Same thing, excision, which is cutting it out with a standard margin. The curettage and electrodesiccation, which is the scooping and burning of the lesion. Mohs surgery, that's the one with all the layers. Medicated creams, freezing it with cryotherapy, liquid nitrogen, or radiation and chemotherapy if it's not operable or if it's spread. Now melanoma, that's what your handout is about, the ABCDs of melanoma. Melanoma is the most important one because it is the most potentially deadly skin cancer, and so we want to catch it early, because early detection has nearly 100% cure rate. So it's important to catch it early. And it's also, it can happen to anybody, not only in light-colored skin, you can have it on all types of people. And if it's found early and treated, like I mentioned, cure rate almost 100%. So these are the ABCDs in your handout. This is the important thing to know when you're looking at your moles. So A stands for asymmetry. So if you were to draw a line across it, does it look different on either side? B stands for border. Is the border irregular, scalloped, or poorly defined? C stands for color, meaning if the area has multiple colors or changes from one side to another. If it has white, tan, brown, black, red, blue, if it has too many colors, that's a reason to get it checked. D stands for diameter. So if the lesion is large, meaning larger than 6 millimeters, which is about the end of a pencil eraser, or evolving, changing through time. Now, just having these things doesn't mean that it's bad. It just means that a spot should be looked at by a doctor. So who gets melanoma? Again, like I mentioned, anyone can get melanoma. And although it is more common in people that have lighter skin, it can happen in people of any skin color. Risk factors include having fair skin, having very sun-sensitive skin, meaning skin that tends to burn and rarely tans, having many moles, meaning over 50 moles on your body, having many large moles, or having many unusual-looking moles. Also having a history of bad sunburns, such as blistering sorts of sunburns, time spent tanning either at the beach or in tanning booths or sun lamps. If there is a family history of melanoma, in this case that would be a risk factor, and also having a weakened immune system. So what causes melanoma? Again, UV light, UV radiation from the sun, or tanning beds, or sun lamps. And having a family history can predispose you as well. So genetics has something to do with melanoma as well. How do you diagnose it? Well, with moles, Usually your dermatologist will use something called a dermatoscope. It's a special little light that magnifies it. Sometimes it's a polarized light. And so we'll use that to take a look at see how the pigment is growing in the lesion. It tells you if it's abnormal or normal. And anything that looks abnormal we'll want to biopsy. The way of biopsying is the same as with the other spots. In this case, the pathology report will look a little bit different. The pathologist will always mention how deep the melanoma is and whether or not it's ulcerated, meaning if the top layer of the skin has opened up. Those are very important in terms of the staging and what kind of treatment would happen. So if it's just confined to the upper level of the skin, that's a stage 0. You cut it out, you're done. Then stages 1 through 4, that depends on how thick the melanoma is. Also depends on whether or not it's ulcerated, if it has spread to lymph nodes, or if it has spread to distant organs. So the staging has a lot to do with the treatment, which is what I mentioned there. Also, patient's health has to do with what treatment we'll end up doing. But if the melanoma is thin, then just standard excision or Mohs surgery is all that's done. If it's thicker or if it has already spread, then that's when an oncologist gets involved, which is a cancer doctor, and they might start doing things such as immunotherapy, chemotherapy, or radiation. Even just a few years back, we didn't have many chemotherapy options, but in the last few years, there's been a lot of new medications, so there's a lot of chemotherapy options available for melanoma. So now, how do you detect it? You learned about all these things about skin cancer, what it looks like, how to diagnose it, how to treat it, what to go from there. Now, what do you do to detect it early so you don't have to do all those things? Well, it's important that you look at your own skin. This is just an example of how to do it, but basically have some standardized way that you have to look at your skin. Do it once a month, once every couple of months. It's best if you have someone at home that can help you, but if you don't, this can walk you through it. So a good way to do it is if you have a full-length mirror, you stand in front of it, you look at yourself front, back, you lift up your arms, look at your sides. Bend your elbows, look at your forearms, your underarms, your palms. Look at the back of your legs, don't forget your feet, the soles of your feet between the toes, between your fingers. Don't forget the back of your neck. Sometimes you'll need to use a little hand mirror to be able to see that. And if you find spots in your scalp, you might have to part your hair so you can take a closer look. Finally, don't forget your back and buttocks. Again, you might need a hand mirror for that. So if you find something that looks abnormal to you, that looks new, changing, worrisome, then make an appointment with the dermatologist so that it can be checked and possibly biopsied. Also, anyone that has had a history of any skin cancer should get a regular skin check by a dermatologist, either every 6 to 12 months, depending on the type of skin cancer, and also how long ago it was. Also, it's important to get skin checks by a dermatologist if there's any family history of melanoma, especially in a first-degree relative. Also, it's important to get skin checks once a year if you've had extensive sun exposure, history of those precancerous spots, the actinic keratosis, history of tanning bed use, history of blistering sunburns, and or have many large moles, many moles, irregular looking moles. So I just went over all these abnormal looking things. I told you how to check your skin so you don't go home, look in the mirror and freak out. I'm going to go over some common things you might find. So seborrheic keratoses, these are very common. Some of you might have these. They tend to happen more commonly on the trunk, meaning on the chest, abdomen, or back, but they can happen anywhere on the body. They can be white, tan, brown, black. They can be warty, kind of stuck on looking. Sometimes you can even take the top of. And the important thing to notice in this photo is that they're all each uniform color, kind of a circle. If you drew a line across it, it'd be symmetric, so they don't really meet the ABCD criteria. Those are all benign. But they can itch sometimes, so they can be a little bothersome. Cherry angiomas, these are very common as well. These are red vascular lesions, so they're a red bump on your skin. They're made up of blood vessels, so if you scratch it, they'll bleed quite a bit. But again, they're benign, not associated with anything bad, so nothing to worry about. Sebaceous hyperplasia is an overgrowth of oil glands that can happen on the face. In people that have oilier skin, tends to happen on the forehead, on the nose, on the cheeks. And they can look a little bit pearly, almost like a basal cell can. So sometimes people get concerned about these spots. They're like, oh, I found a basal cell, and it's actually one of these. It looks slightly different when we look at it with our dermatoscope. That's our little light. It looks more yellowish, and the blood vessel pattern is different. But if you have these bumps, it's probably a good idea to make sure they look okay. Skin tags, also very common, completely benign, but very annoying. They're just benign growths of skin. They tend to be skin colored, kind of pedunculated, so they stick out of the skin. And they're more common in areas of friction, such as the neck, the underarms, or the groin area. Sometimes they can be painful or itchy, but the majority of the time they're asymptomatic. Dermatofibroma can also happen a lot of times on the lower leg, but it can happen elsewhere in the body. It's just a very firm, kind of dome-shaped bump on your skin. Can happen after having some sort of injury, like a cut, or having a bug bite, and then the body kind of has this response where it forms this hard bump. And then finally, moles. So moles are common. So just because you have moles doesn't mean it's something abnormal. They can happen almost anywhere on the skin. They can be all sorts of colors. They can even grow hair. People with light skin and people that have had a lot of sun tend to have more moles. But remember your A, B, C, D, E's and check your moles and see if your moles are okay. So some take-home points. 1 in 5 Americans will be diagnosed with skin cancer in their lifetime. Anyone can get skin cancer regardless of their skin color, although those people with fair skin are at higher risk. When caught early, skin cancer is very treatable, so check your skin. Go see a dermatologist if you see anything abnormal. And there's really good information on the American Academy of Dermatology website, which is the aad.org website. They have photos, handouts, all sorts of information. You can search for dermatologists that are board certified on their website, so it's a good place to go. So any questions? Yes?
Could you repeat the website?
Oh, yes. So it's www.aad, and that stands for American Academy of Dermatology, .org. Any other questions? Yes?
How does skin cancer kill a person?
So if skin cancer, if it spreads, so that would be more commonly the melanoma. Just like any cancer, it can invade normal tissue. And so a melanoma, that can go to the lymph nodes, it can go to the liver, the lungs, the brain. So like other cancers, it just invades to a point that it just doesn't function normally. So that's why it's important to catch it when it's on the skin before it spreads. Yes?
Can you tell me the difference between the Mohs, MOHS, and the elliptical procedure?
So elliptical excision is that excisional surgery that I mentioned. So the excision, there's a standard margin that is taken. So depending on the type of skin cancer, it might be 5 millimeters, 1 centimeter. And so for every skin lesion, you just look at where it is, you get a ruler, you measure around it, and you make kind of a football shape around it so that it will lay down flat, and you just cut it out. With the Mohs, it's different. You actually get a very narrow margin. You get really close to the spot. A lot of times that means that some of the skin cancer is left in the skin, but you're trying to preserve the greatest amount of normal skin. And so that's when the Mohs surgeon will check it under the microscope and see if they got it all with a first narrow margin. But if there's little roots, then they'll just go and get those roots. But it ends up being a smaller surgery a lot of the times than the elliptical excision. But it takes much longer because there's all these layers and steps. So sometimes it'll take a full 4-hour morning to get the whole thing done rather than maybe half an hour for an excision. But that's what we do for face, hands, and also for feet.
So there's really probably no difference in, say, your diagnosis, be it squamous cell
Or basal cell.
or, well, no, basal cell. I was trying to think of, well, when would you go for one versus the other?
Depending on the location of the body where the skin cancer is, how big it is, and what type of skin cancer it is. So basal cell and squamous cells, we treat them very similar, but if they happen on the face, then we do Mohs micrographic surgery, versus if it happened on your arm, we do the standard excision. However, if you have a very large spot on your arm, that means bigger than 2 centimeters, which is about 1.5 inches. If it's very large, that's when we were trying to limit the size of the surgery, and so that's another reason that we might do Mohs surgery. Also, certain types of very infiltrating skin cancer, so skin cancers that appear to be deep, we might go to Mohs surgery on the arm, for example, as opposed to a surgical excision, elliptical excision.
Thank you.
Yeah.
How many different kinds of cancer are there, skin cancer?
So these are the most common. There's quite a few other ones. There's also angiosarcoma, there's Merkel cell carcinoma. There's other ones that are much rarer, may be more aggressive, but those are not common. They're very rare, but we do see that.
And the only way you tell what kind it is by looking under the microscope?
So we can get a lot of clues by looking with our eyes and looking with that little derm light, which is that light that I was mentioning that we use. But the only way to get 100% an answer is by doing a biopsy, looking at it under the microscope. Exactly. Yes?
Are any of the cancers like itchy, burning, do they hurt or?
A lot of times they're painless. They don't hurt. Sometimes they itch, but the main thing that they all tend to do is bleed. So anything that bleeds certainly should be checked. But they don't always hurt because they could be just very superficial. If they do hurt, it's the ones that tend to be a little bit deeper, or if they happen like under the nail, like certain areas of the body can be painful. Yes?
What do you see when you look at it under the microscope? Just a lot of blood veins, blood.
So when we look at it under the microscope, the tissue is stained a certain way, and then it's kind of sliced so we can see thin layers under the microscope. And then we look at all the layers of skin, so we'll look at the top layer, the epidermis, the middle is the dermis, and then the fat underneath. And then we look at the type of cells, and each cancer is an overgrowth of a different type of cell. For example, basal cell is an overgrowth of the cells that make up your hair follicle. Then squamous cell is an overgrowth of atypical skin cells, and melanoma is an overgrowth of the melanocytes, which are your pigment cells. So you look for the type of cell, you look at how they look like. They're usually either too big or abnormal looking, also the pattern of how they're growing. So there's lots of clues to be able to tell which one it is.
Well, our skin cancers are not related anyway to internal cancers like breast cancer and things like that. They're not related to that. They're entirely different.
Right, they're different because a lot of times they're strictly caused by the sun, although there are some genetic syndromes where you can have multiple types of skin cancers in addition to internal cancer. The majority of the time it's just direct damage from the sun causing it. Any other questions?
I do.
Yes.
The clothes that have an SPF,
Right, UPF
protection,
clothing.
UPF, how good are they at protecting?
They're very good. So those clothes, the way that they work is that they're very closely woven, so there's not that many space for light to get through. And so they work really well. If you have a tightly woven other sort of clothes, then that would work as well. But with those UPF clothes, they actually test them. Some of them actually put some sunscreen in the fabric, but the majority of them, it's just that they're tightly woven so the light can't get through.
Well, my husband has vitiligo,
Okay.
and even though he puts a lot of sunscreen, he still gets red. Is he getting the protection that he needs with the sunscreen as well as putting the, using that type of fabric?
Right, so he should be using more sun protective clothing if he can. Obviously on the face it's hard, but using the zinc sunscreens are the best because they just kind of bounce the light off, and then just reapplying the sunscreen. But the clothes work better than the sunscreen.
You don't recommend any sunscreen over another one other than the 50, at least 50?
So just as long as they meet the broad spectrum and the SPF. I mean, I have my own favorites depending on how greasy they are or how white they are. But other than that, it's just by your preference. Everyone has a different preference.
Do you like greasy ones?
I don't, no.
No? Well,
But some people like them.
And that has moisturizer in it then?
So some of them are oil-based, so those are the greasier ones. A lot of the spray-on ones are like that. Some of them are more cream-based, so they're kind of cakey. But some people like that. Some of them are powders. There's all sorts of sunscreens. There's, also foams.
Well, then if you use a moisturizer, you would put that on first and then the sunscreen if you have them separate?
You would put the sunscreen on first
Oh, the sunscreen.
to make sure you get a nice layer. Yes.
And then put the moisturizer.
Yes. Yes.
Is there any evidence that fluorescent tubes, lights from fluorescent tubes could cause?
You mean like lights like this?
Yeah.
It's unclear whether or not it does. The thought is probably not, but I don't think there's been a great answer for that because it's hard to study that. Any other questions? Yes.
You mentioned things not to worry about, like moles and skin tags.
Yes.
I guess I've always been confused. I guess the moles, it's just that they're dark, because I've seen moles that hang out people's skin too, like the skin tags.
Yes, moles, that's where it gets more confusing because moles can do all sorts of things. They can be flat, they can be raised, they can be almost like a skin tag. They just look a little bit different when we look at it, and it looks different under the microscope. But those were kind of the most common look for them. The majority of moles would be more flat rather than like a skin tag.
Do you remove them the same way?
We remove them the same way, yes. We would numb it up and kind of cut it at the base. When the skin tags are much easier to remove because the bottom is very small. And so even though it can be quite large, really you just have a tiny scar at the bottom once you remove it.
Are there any new developments in skin cancer? Anything new that's just come out? Or?
Well, for melanoma, there's been a lot more chemotherapy medicines in the last few years. So that's been the newest thing, the new exciting thing for us, because for many years, there was no specific chemotherapy. They were using chemotherapy that was used for other cancers and basically just trying it out on melanoma. But now there's a lot of specific targeting the mutations that happen in melanoma. So that's exciting. That's been happening the last few years. So we have a lot more treatments.
Would there need to be a grade level? In other words, 1, 2, 3, 4, 5 in the melanoma that would indicate chemo is?
So it depends on the depth. So if a melanoma is deep, then that's when it's recommended that the lymph nodes are checked. Then if the lymph nodes are positive, then that's when you need to do a PET scan. That's a scan of your whole body to see if it has spread. And that's all part of staging. Staging helps you, getting all that information helps you know which stage it is. And then the treatment is different depending on the stage. But at that point, it's usually the oncologist, meaning the cancer doctor, doing that workup and treatment. And the dermatologist does mostly the treatment of the thin melanomas. Once they're a little bit thicker, then they go on to see the oncologist for that treatment. Yes?
Could you put the various stages back up on the
Yes.
screen again? Thank you.
Sorry, it's kind of small.
That's all right.
Did you have a specific question about them or just wanted to look at them again?
I just wanted to read them.
Okay.
Yeah,
I know if you're,
So this lady mentioned about using sunscreen and moisturizer.
Yes.
And I've always put the moisturizer first and then the sunscreen, but you're saying I should do the reverse?
It probably isn't a big deal which way you do it. My thought is that you're making sure you get a nice layer and it's actually absorbed with the sunscreen, and then you put the moisturizer on top. Otherwise, if you do the moisturizer first, that's absorbed better, and the sunscreen doesn't absorb as well when you're putting it on top of that. So the same way if you have any sort of medicated creams, so like if you have a rash, you should put your medication on first before the moisturizer.
And then you should wait the 15 minutes before you go and put something else, so you don't.
Exactly,
dilute it, right?
exactly, yes. Yes.
There's some commercials about topical ointment or something for skin tags that's supposed to help with skin tags.
I've seen a lot of magazine commercials for that. I haven't heard of any of that been like studied or proven in the scientific side, so I can't say whether or not it works because there haven't been many studies at all, or any that I'm aware of, for those products. They have claims and things. A lot of times I think the idea is to burn the spots away, but with that you risk causing scarring. So I don't know exactly how they work, so I can't really speak to that.
Well, if you had melanoma, then supposing you had it on your ear and it wasn't taken care of, it can go deeper into your scalp.
Right, it can go deeper into your skin, and it could go into your scalp depending on where it was and how it grew, and eventually could spread to lymph nodes. So yes, it's important to get it checked.
So it can all go internal into your body then, right?
If it's been there long enough, yes, if it's something like a melanoma.
Into your brain?
It could spread, yes, but usually it would spread to the lymph nodes first. So not directly spread into your brain. It would more spread to your lymph nodes, and from your lymph nodes it can spread to other organs, including the brain. But the idea is catching it when it's just on the skin.
Right.
That's a wart, it's not cancer.
Yes, there's certain ways that the wart looks. It has vessels that are a certain way, so that we can tell the way that it's growing and the warty look that it has, whether or not it's a wart.
The person who has the wart, is there something that should warn us?
Oh, you're talking because of the HPV risk, the human papillomavirus? So where?
Look at one and say, hey, that's a wart, or that's not something else.
I see. Well, by having someone take a look at it, that's the best way to know. But the HPV virus that can cause warts, I was talking more, the ones that are risky is when it happens kind of in the mouth or in the genital area. The common warts that happen on the rest of the body, those are different HPV viruses. They don't tend to cause skin cancer, so it's a different type of wart.
If not, thank you very much,
Yes,
Dr.
thank you, everybody.